You're listening to the Physio Matters podcast this month in association with Connect Health, and this is session 51. Welcome back to Physio Matters. I'm Jack Chu, and I'm back from my honeymoon. Thanks a lot to the team, especially to Rob and Jack, for sorting out the podcast while we were away. We had a cracking time, recharged the batteries, and ready to go again. Sorry that this episode's a little later than we usually put them out. First Sunday of the month's our usual slot, so we ended up on the second Sunday. Just purely, we've had a couple of technical difficulties, especially regarding the website. Apologies if you've noticed that and been struggling, but it should all be resolved. And we're going to go on to a new server in the next couple of months that's going to hopefully handle the capacity that we need better than we have done. So again, apologies. Got a few events to tell you about before we get cracking. I'll be in the Netherlands on the 22nd of March, so come and say hello. We've got an event, I think there's an event page, check us out on social media. I think it's my pinned tweet at the moment if you want to come along to that. We're doing like a big Q&A sort of discussion session. We'll try and set up some sort of live feed, so we'll push that onto Facebook or YouTube. And then the International Physio Students Meeting is in Faro, Portugal, and so on the Algarve, and that's on the 27th of April through to the 1st of May. And so that's going to be absolutely brilliant. Any students listening, especially, it's difficult to get British and Irish students there because it's right in the thick of like exams and placements and stuff. So I totally understand if you can't make it, but if you're listening from overseas and you fancy getting involved with that, then please do check out IPSM 2018, and the team there will sort you out with all the information you need to know about coming and getting involved. Really interesting session. I was there a couple of years ago, and I'll be contributing a lot to the program this time round. So do check that out. It's just a brilliant trip as well. You know, independent of the learning environment, it's just a really cool place and a really great holiday at a really great price. So do check that out. We're super busy through April. The 19th of April, we'll be at the PRS, Physio Research Society's annual conference, which is in Northumbria this year. Do check them out, physioresearch.org, and sign up for that brilliant lineup that they've got. I'll be moderating a discussion, like a panel discussion on sort of integration of evidence into practice and things. So which will be brilliant, but also the rest of the roster looks ace. So do check that out. Which is the day before we're doing another hashtag the Big R's event, sort of twice the size pretty much. So again, we had to try and contain it somehow, so it was invites, but we scaled it up and people were able to nominate and stuff, which was good. So mainly, like last time, it's people that have really supported the podcast and stuff, that want to try and instigate improved messaging and trying to see if we can instigate changes and reforms within the profession. So we'll be having those conversations again, and we'll be live streaming 2 panel discussions from there, one on reasoning, one on responsibility, and then we're going to do big sort of roundtable discussions around the concepts of reform and how we might go about that, and sort of the hows and the whys of what we're doing. So that's really cool. So keep an eye on that, hashtag the Big R's, and the live streams that will come from there on the 20th of April. Website going live for that movement and project if you want to keep an eye on it. It's it's www.reform.physio. Just a holding page there for now, but it's going to go live in a couple of weeks, including a forum in which you can interact and try to instigate the changes that you might feel are necessary, and also pull the brakes where you think we or others are getting carried away. And then save the date for 5th and 6th of October this year. We're going to do our first conference, which we've long talked about but never got round to. That's going to be awesome. We're putting that together as part of the Big R's project, and so you can keep an eye on social media for that. We're going to be announcing keynote speakers and the plans for what panel discussions and stuff we're going to have, and that's all going to be out there on social media pretty soon. Keep your eyes peeled. And finally, podcast loudmouths Adam Meekins and Eric Meara from either side of the Atlantic are doing a course in London, 9th and 10th of June. I offered a free space to us, so we're going to be running one of our social media competitions, so retweets and shares and stuff will get you into the ballot for that, as well as patrons, of course, get extra entries and often seem to win these things because they get like 15 entries or something, which is cool. So join us on Patreon, of course, if you want to get in on that ballot. But that's a shoulder and knee course with Adam and Eric, and I've heard great things about their courses, and so it'd be great. Hopefully, we can try and get a microphone under Eric's nose as well. Get him on Physio Matters for you if we can get ourselves down to that event. Certainly hope to see you there. Talking of podcasts, we should do an interview, shouldn't we? I'm really pleased to bring you this podcast on red flags with Connect Health, sponsored by Connect Health, with one of their APPs, Andrew Cuff. One of the things we didn't cover so much in detail is cauda syndrome. I reckon there's a separate podcast in that, really. A few names come up in the podcast, so I think I'll probably chat to maybe get someone like Laura Finucane or Chris Mercer or Sue Greenhalgh or something like that, maybe, or the whole job lot of them. I know they do courses and stuff together, so maybe we'll try and get a cauda equina podcast put together at some point. So that isn't covered in significant detail, but otherwise, as you'll see, we tend to cover a lot of ground in and around red flags, which I think it's super important, and I really appreciate Andrew's helping us bring this together. A really interesting conversation, really important stuff, and so I hope you enjoy it. So without further ado, for all the waffle from me, I bring you Andrew Cuff. Delighted to be here today with Andrew Cuff, who's joining us to talk about all things serious pathology, something that he lectures on, but he's going to tell us about that, I'm sure, in his intro. Interesting that this was a topic that was raised by Connect when they were talking about what sponsored episodes they were going to cover when they did a bit of a 3-podcast plan with us. And you've heard clinical excellence, and you've heard the panel discussion that we had at the Big R's event that you might have found on YouTube. Go and check that out if you haven't already. So the third one's going to be a clinical podcast, and very interesting for them to then put forward something that is at the forefront of the triage, the front end of what we find clinically, where we're trying to screen for serious pathology. I need to get used to saying that word in this podcast, pathology, for making sure that we are directing people to the right things as a matter of urgency. And one of their staff members, although I know Andrew from before he was with Connect Health, and so it's really interesting to have watched his career journey unfold, which I'm sure he'll tell us more about in a second. But it's great for him to come on the podcast and be able to talk about all things red flags and serious pathology. So I said it right the second time. So welcome, Andrew, and please do introduce yourself for the listeners.
Thanks, Jack. Well, thank you for inviting me to talk, really. It's an honour to kind of be on something that's really been with me on many journeys to work. So it'd be a bit strange if I have to listen to myself back on Monday morning. My name's Andrew Cuff. I'm an advanced practice physiotherapist, which in old money is an extended scope physiotherapist, and new money an APP for Connect Health. And I'm the clinical lead for the Wakefield Musculoskeletal Service and the North Kirklees Musculoskeletal Service. So I do that 4 days a week. And on my 5th day on my working week, I work in private practice with at a clinic called the Sheffield Shoulder Physio, which is a second opinion clinic for predominantly shoulder and elbow cases, but I still get a bit of everything coming through, really. And when I'm not in clinic, I'm a lecturer and do a bit of teaching. So I teach on red flags, I teach on systems thinking and the upper limb predominantly. And that kind of led me into my most recent role, where I've just joined the education committee for the European Society of Shoulder and Elbow Rehab.
Fantastic. And you've got some academic credentials worth mentioning, because I think that's when we first interacted, was on social media a few years ago, where I was interested in some of the things that you were uncovering when you had taken a deep dive as part of your masters. So where and when was that?
Absolutely, yeah. Well, I kind of forget about my academic past, really. Mm-hmm. So I got into the academic world quite early on in my career. So probably about a year after qualifying, I became a research physio at the University of Warwick within trauma and orthopaedics. And I started doing this job alongside my masters. So I kind of went a bit of an unconventional route, really, where I was involved in academia relatively early on in my career alongside clinical practice, which most people will go through a lot of clinical practice and then go into academia. And I think that gave me really useful insights into my reasoning processes, my understanding, I hope, of evidence, and also the daily application of that into clinical practice. I really enjoyed that. But now I'm a full-time clinician. which again probably wasn't expected. I always thought I'd be involved in academia in some extent, but it's great how these pan out, and I'm enjoying being a full-time clinician.
No, that's brilliant. So, in terms of the topic that we're going to discuss today, and how has that become one of several areas of interest and something that you then have come to lecture on across the sort of CPD scene?
I'm not really sure, to be honest. It just kind of happened. I enjoy reasoning, and I enjoy thinking, which makes me sound really, really interesting.
Is that that's on a dating profile bio somewhere? I'm sure.
If I've got a dating bio.
I wasn't meant to mention that, was I? Sorry, go
That's how we met.
on.
No, so it just kind of naturally around kind of red flags and picking up, not necessarily serious pathology. I think this is something we're going to come on to in how I view or what I view red flags to be, but also the specific pathology of, am I the right person for this patient in front of me? And particularly when we think about my interest being in the upper limb, that's not really where we kind of knee-jerk go to when we think of red flags. And that's what kind of interested me, thinking as a clinician, as somebody who is still very much with a strong rehab caseload, but also working in the advanced practice clinic, knowing when the person sitting in front of me needs to be sitting in front of me, and when that person doesn't need to be sitting in front of me, is what interested me, and the reasoning process and the reasoning journey behind that.
So red flags is part of a wider piece for you, where you're recognizing who is and isn't appropriate for your skill set at that moment in time. So that'd be red flags. There'd be other masquerading variables. There'd be more overt structural pathology requiring surgical attention. This was part of a triage layer for you then, was it?
Essentially, yeah. And I think really for me, it's red flags. We think about red flags usually as kind of sinister pathology. I don't really like the word sinister, because it gives the kind of impression that something evil or something harmful is happening. But I like the term serious, I like the term specific. And for me, it might not be that we're picking up something which is necessarily life-threatening. It just means that it's not a musculoskeletal presentation. So it could be something that's masquerading. That to me is part of my red flag screen. Or it could be looking at kind of a specific presentation. So if someone comes through to see me, they're relatively fit and active, they describe a level of trauma, and they've got shoulder pain, and they're struggling to lift their arm up. It's got full passive movement, positive lag signs, and I'm thinking it might be a big full thickness cuff tear. To me, that's a red flag. If I'm seeing them relatively early enough, they don't need to be seeing me. They need to be going to speak to an orthopedic surgeon. So I would class that as part of my red flag reasoning process, or taking me away from my bias in the upper limb. If I see an acute meniscal tear and an acute locked knee, that to me is a red flag picture or red flag presentation that I need to ensure that that patient or that person gets seen on the right pathway and being seen by the right professional to help them go forward and kind of get their quality of life back.
That's something worth lingering on, though, I think, because you're describing the parameters around the term red flags and what it means to you there, which is different for different clinicians on something that, at least compared to other realms of practice, it is considered something we should be more objective with, and we should all sort of be singing from a similar hymn sheet. Whereas for some people, it is more to do with the details of serious pathology, or for other terms, sinister pathology, which a large cuff tear and an acute locked knee wouldn't necessarily come into. So what are your thoughts on that? I mean, you've given your take on where you've landed and why you consider them that, but do you have sympathy for those that would say that is a foolish over-broadening of the term? Can you understand why you might get that critique?
Oh, absolutely, yeah, and it's something I'm mindful of, and I think again that's what interests me. Is I think we're seeing it already that red flags shouldn't be dogmatic. They shouldn't be part of an algorithmic process. I think they are open up to a bit of interpretation. And in relation to it being a bit of a broader definition, yeah, I take that. But I think that then comes down to the role that I'm in. So if I was working purely in a spinal clinic, I can see how that is probably a little bit too broad. Because when we're thinking red flags, we generally think spine, and we're trying to pick up those specific or those sinister pathologies. But working in a community musculoskeletal setting, where I could be seeing anything from a trigger finger down to a claw toe and everything in between, my reasoning processes do have to be quite broad to begin with. They have to be quite panoramic, and then I might zoom in and start kind of getting into the detail a little bit. So I'm not saying it's the only definition of red flag, or one that is necessarily a correct definition of red flag. It's definitely open to critique and open up to debate. But in my head, when I'm going through that process, it's a reasoning process of working out, does this person have anything sinister, or does this person just have something that is a specific pathology that needs to be dealt with in a different pathway along a different management process?
Because I can comprehend that, and I think that's a totally justified position, and I think you could argue it well. But where the rubber hits the road on this podcast is that if me and you were to title this as a red flag podcast, and then we spent an hour then talking about just overt orthopedic cases, namely large-scale cuff tear in a locked knee, then people would rightly smell a rat, wouldn't they? And so there is I suspect that you account for those sorts of things in those are cases on the periphery of what would be considered the term red flags. And for today, we're gonna focus on other things. And so there are centric circles almost that I suspect, but I don't want to overassume.
Yeah, you're quite right, absolutely. So I won't be talking about big cuff tear today. That'd be too comfortable for me to talk about. We will be talking about the kind of those sinister or those masquerading presentations, as opposed to the specific musculoskeletal pathology. But this may be just a point of reflection, really, that when we are reasoning out red flags, we are reasoning through this process. I'm just mindful that those specific pathologies may come under that broad umbrella in terms of the kind of clinical setting that I'm working in.
What I want to ask first is, I wondered if you could account for what would demonstrate a lack of respect for serious pathology, first and foremost, and what would demonstrate excessive vigilance?
Absolutely. So if I take the latter end of that question first, in terms of the excessive vigilance, and I suppose this kind of feeds in with what we've just discussed, really, in relation to what are red flags. Red flags aren't diagnostic. They're never supposed to be diagnostic. The intention of red flags really were just to make the person think, or make the clinician think, or indicate that possibly that the condition in front of them is serious or a non-musculoskeletal one. So excessive vigilance to me would be utilizing red flags in either an algorithmic approach or in isolation, and not having any context or reasoning behind it. So for example, I'm sure we'll talk about this in a bit more detail, but the use of something like the past medical history of cancer as a blunt tool. I was seeing somebody coming through with a presentation, whether that be low back pain or shoulder pain or whatever, and then taking the medical history and anything I need to be aware of. I know I was previously to the diagnosis of cancer, and then the alarm bells start ringing. That patient gets escalated up. They might be investigated. They might be referred on, and it could just be a normal mechanical benign presentation, but the reasoning stops. The alarm bells have gone off, and that patient's being moved along the journey. So that to me would be an example of kind of excessive vigilance. Whereas on the flip side of that, in terms of a lack of respect, I suppose it's those circumstances where I've been in clinical environments when people are going through their clinic list, in days gone by, it would be done on paper, looking through the referral, and they see chronic lower back pain, past medical history, fibromyalgia, anxiety, depression, whatever, and so on. And then the reasoning process stops. It's almost how quickly can I get this through this consultation before I get this person out again? And that to me is the complete lack of respect, because often with serious pathology, particularly around the spine, is that they present very similar way to complex pain presentations. And for example, if we think about Louis Gifford, he wrote quite a poignant quote, which I often come back to, is that there is not a dichotomy between persistent pain and serious pathology, but in fact they can present very similarly. And this might be a bit of a newsflash for some people, but people with fibromyalgia can still get serious pathology. It's not a protective factor towards serious pathology. And if you stop your reasoning process there, then I think that demonstrates a lack of respect for adequately being vigilant to these potential presentations or underlying presentations.
And so at both ends of that, then you've identified people relying too much on a flowchart, a algorithm, rather than a reasoning process in which they are waxing and waning the index of suspicion for conditions. That's easier to say with some experience and mileage under your belt, because people do find themselves usually starting with at least some baseline frameworks in which they're asking questions in order to get through an assessment. We all know that the sort of student new grad manner of doing so, it can't be quite as loose leaf as you or I might do. So how do you best account for that? And in red flag terms, do you have some sympathy for the fact that people might feel that there's just certain questions, certain boxes that they need to tick as a matter of safety?
Absolutely, and I'm not saying that we shouldn't have prompts or kind of templates as part of the clinical assessment. I think that, as you quite rightly say, it provides the framework for then your reasoning process to kind of fall out from. But it's more for me the action of, if we've got an assessment template with 6 red flags on, say, for example, night pain, a history of cancer, osteoporosis, fever, and someone's ticking, okay, I've got 3 out of the 4 here, they're not for me. I need to send this person back to the GP, for example. That to me is just you've ticked 3 boxes, but where's the context? So how does that relate to the person's presentation in front of you? Are they relevant? Does it fit the picture? Does it fit the pattern? And it might do, but it should be more than the box ticking or more than the information gathering. It's the clinical reasoning behind it, which would be a bit of a concern for me, really.
Yeah, no, I can understand that. It's certainly, there's been a temptation, hasn't there, at times, and in certain sectors and corners of practice, where people will think it can be used like an early warning trigger system for patient obs in inpatient care. It's sort of this idea in which if we can finally get a system in which we can have a binary yes nos and then do the sums, then that will tell us when to send someone to A&E or for imaging. So no, I'm with you there for sure. In terms of before we wade into some of the specifics, I want to just talk about some of the stuff that we're not going to really talk about, which is what red flag variables do you feel hog the limelight, and do they deserve it? So we have this thing in the Physio Matters team where we sort of joke about people don't just have red flag thoughts, they have pet flags, and people have their favourites and things that they know more about, whether they wrote an essay about them or they happen to have been better read or better reasoned in that direction. Do you feel that's sort of fair for us to smirk at, and you recognise that? And if so, what sort of things do you feel do, as I say, hog the limelight and get a lot of attention?
Absolutely. Well, I suppose we usually, you're quite right, people are quite comfortable talking about things that we know a lot about or have at least got some insight into. And I suppose in terms of the red flag kind of topic, now I probably need a little bit of a precursor here. I'm not playing down the importance of them. They are definitely very important. There's been some great work done around them. And I do think that the reason why they hog the limelight, so to speak, is because it's what we know the most about, but also some of the consequences associated with them are quite severe. But I think if we ask any kind of junior physiotherapist or a new grad student about red flags, they're probably going to talk to me about bladder, bowel, and saddle anaesthesia from a cauda equina perspective. And obviously the consequences of missing cauda equina are well known, both from a patient-centered quality of life perspective, but also from a litigation perspective. And if we think about those templates we previously alluded to, those are where you'll see bladder change, bowel change, saddle anaesthesia on that. So I think people are quite comfortable with how does cauda equina present, what questions might I ask, and I think most patients, or most physios, when they have a spinal patient in front of them, will be asking those questions. I suppose to some extent also the around metastatic cord compression. There's some great resources from Sue Greenhow and her group in relation to kind of the warning cards for patients, as well as kind of resources for professionals. So I think when we talk about red flags, we know a lot about that. We talk a lot about the spine. We talk a lot about those presentations, and I suppose we've kind of already fallen into the trap a little bit in that when we do think about red flags, we think about the spine. Sure. And again, going back to my bias around the upper limb, but also working in a community MSK setting, you've kind of also got to be that specialist generalist. You can get red flag presentations in the periphery. I'm not quite sure that gets talked about as much or considered as much in daily practice. I know from going on courses myself or from attending conferences, it's almost once you've ruled out red flags, make sure you go on and do this part of your assessment process. And I know Alan Taylor who put that quote, which is great, if we don't rule out red flags, we remain vigilant to them. But I'm not quite sure we're as vigilant in the periphery as we are in the spine.
No, I think that's certainly accurate from my experience too. When we're trying to parse out whether or not they deserve the limelight, shall we say, do you feel we're in danger of potentially zooming in too closely to some of those things and potentially distracting from the reasoning process that we described? Because the more we know, the more tempting it might be to become more flowchart based, because there are certain things, and I mean, namely, someone's acute presenting with what could be considered an acute radiculopathy, then he's retaining urine and has lost some bowel control with numbness in the saddle region. You are starting to get into a situation where any inference in that direction, whilst we should be applying it to a reasoning framework and the context does matter, it's still a cluster of things that is sufficient to trigger a response compared to other vaguer areas, namely in the periphery, in which you literally couldn't form an algorithm to because even if you wanted to, because there's so little evidence of cause, if for want of a better term.
Absolutely, and I think I totally agree. Because we know how these present, well, we know a little bit more about how these present. We've still got a lot of work to do in relation to cord requirement, a lot of work to do in terms of metastatic core compression, because we often picking it up when it's already become an established process. Some of the things like, for example, if we're thinking about metastatic core compression, walking a little bit funny, bound-like pain, legs feeling a little bit odd, often they're late stage. What we're trying to kind of work out is how do we pick them up a little bit earlier before we get to those late stage symptoms. So I don't think we run the risk of necessarily going too far into the detail there, because we still got a hell of a lot to learn. Mm-hmm. And I think probably a piece of work I would allude to here is Sue Greenhow's qualitative study on cauda equina, because although we know that the blood is involved, bowel's involved, central anesthesia is probably one of the most sensitive features, and either unilateral or bilateral leg pain, every one of the participants in her study, in her population, whilst they had the same symptoms or similar symptoms, the order in which they came on were very much unique. Mm-hmm. So whilst we've got the inference there that we think a cauda equina process is ongoing and we need to action it, there's still a lot we don't know. So I don't mind really too much if we do kind of keep bringing it on, because the problem is if we stop talking about these things, we'll forget about them. And it's good and it's really important that we are keeping them forefront of our mind. What I'm probably saying is, let's put the same level of detail and the same level of work on the things that we don't know as much about yet. But that might be harder because the prevalence is lower.
No, I can understand that. I think that's certainly a reasonable line to draw. And when working in MSK practice across the broadness that you described at the moment, what are the conditions that you feel we should be most aware of? And what red flag indicators are most helpful in raising or reducing the index of suspicion in that direction?
Of course. So something we've already kind of alluded to, metastatic core compression, cauda equina, trying to pick up tumours. So again, thinking around the upper limb, think about like a Pancoast tumour, or kind of things like osteosarcomas, which I think again we're relatively aware. There's an awareness amongst clinicians that how they can masquerade almost like a frozen shoulder. We've also got to look at things like vascular presentations. Now, we can't do a red flag podcast without talking about AAAs, or we'll probably get shut down.
Absolutely. How dare you?
But then one of the presenting, or kind of the early presenting features of a AAA is often non-specific low back pain. Now, if someone comes through with non-specific spinal pain, that might not end up in the advanced practice clinic. I'd hazard a guess it probably wouldn't kind of turn up in an advanced practice clinic. So maybe one thing to highlight as part of the podcast is that you and I both work in CATS clinics, we both work as advanced practitioners, but these patients can also present in the GP practice if you're doing first contact clinic, if we're moving more towards self-referral. So it's really important as a clinical workforce we continue to upskill. And interestingly, around AAA that I just kind of alluded to there, the last person that I had a suspicion of and ended up referring on for investigations was actually my own dad, who he was trying to help me move house just before Christmas. And naturally, we've got everything in the house. I thought that'll do. We'll go to the pub. And living in Yorkshire, in God's own country, there's lots of rolling hills, and his dad was walking up the hill. He was getting this flank pain, this really bizarre flank pain. It was causing him to kind of double over. And naturally, as we're talking about index of suspicion, it should never be dropped, not even at weekends with your parents going to the pub. And I said, I do right now, I can't. And it was changing side to side. And this happened a couple of times over the course of the weekend. Until finally, on the final day, he was walking up a hill and he got bilateral leg pain. So naturally, I got him bending over in the middle of the street to try and differentiate a neurogenic kind of presentation from a vascular presentation. And his leg pain still remained despite bending over. We walked a little bit further and he had to stop again with this bilateral leg pain. So on Monday morning was writing a letter to my dad's GP to get him sent on. He's undergoing the investigations at the moment for it. Wow. So yeah, definitely vascular, not just in the clinic, but also at home.
Yeah, before you go on, worth me mentioning, because it sounds like we've both got a real pair of examples, because my old man had cauda equina last year, no, 2 years ago now, which was of interest and potentially something for another podcast. But it certainly maps on to Sue Greenhalgh's work that you've mentioned before, where this if you were to map his story, it would be considered atypical. However, for it to be atypical is typical from what we now know in terms of the onset, the way in which the symptoms came on and the way it was behaving. So worth mentioning. But anyway, do go on. We're talking about
and what we see in MSK practice. So we think about the things like you mentioned, tumours, vascular presentations. Naturally, within MSK, you're always on the lookout for rheumatological presentations. Things like your spondyloarthropathies in the spine, but also in the periphery as well. So picking up rheumatoid arthritis, and I can never really pronounce it very well, but psoriatic arthropathy. Sorry, Jack, if you're listening. And as well as some of the kind of neural presentations as well. So things like myelopathy is quite a big one. And I suppose if we're thinking around the head and neck, cervical arterial dysfunctions and cranial nerve features, all these things which they can masquerade as musculoskeletal presentations, and often, particularly the way practice is going, these might be sometimes the first people to start asking the questions that raise that index of suspicion. And one thing that has come onto a couple of things that have come onto my radar, particularly in recent months, are things around kind of avascular necrosis, which, again, I think people are often quite comfortable with looking out for it in the shoulder, but you can get it into the knee as well if we're thinking things like spontaneous osteonecrosis of the knee or SONC. But I've had 3 Kienbock's disease this year alone, and we're only in March. So it seems to be a bit like London buses. I've not seen a Kienbock for about 2 years and had 3 in 3 months. And I suppose the other one that's come onto my radar, and is one that I think as clinicians, particularly working within community MSK, we're going to see more and more of, is around looking at insufficiency fractures and bone injuries, which again I don't think are necessarily, well, they definitely weren't on my radar as strongly as they are now 12 months ago. So those are the kind of things I'm constantly on the lookout for, really.
Yeah, of course, and that goes back to the first thing we came to talk about, which was the broad scope of what red flags mean, and what we're considering when you zoom out enough to consider all masquerading variables. It's about recognizing what is and isn't for us to plow on with. Now, before we start passing out some details, I'm going to start
Mm.
wading through sort of profiles of cases and things like that in a
Yeah.
second. But before we do that, do you feel that there is then a difference between checking about the remaining vigilance bit? I suppose is if I try and spit it out, is to say, do you feel that it is a constant ongoing process, or is the vast majority of the screening process done fairly early doors in the patient journey?
I think there's probably kind of two questions there, really. One, do I think that is what's happening? Yes. Do I think that's what should be happening? No. So I think you're quite right. I think we open up our list, we'll see a certain number of new patients coming through, and I think we're quite comfortable and quite kind of used to, as part of our subjective assessment, is to, in inverted commas, rule out red flags, or screen, again in inverted commas, red flags. I think then our index of suspicion can drop off a little bit. And like we've kind of alluded to, with kind of serious pathology, particularly with things like cancers, is we know they wax and wane over time. We know there's not a linear deterioration. And that can lead us into a bit of false reassurance as kind of clinicians, really, in that we might see a patient, we've ruled out red flags, again, inverted commas, in the first assessment, we do some treatment with them, and they're getting better, and our index of suspicion drops even further. But then they come back and they're worse again. And they might have actually deteriorated a little bit. So at that point, we might kind of pick up our index again, or we might not. So I'm not sure that the index of suspicion or the vigilance is necessarily being sustained throughout the patient journey or throughout our interaction with the person. Do I think it should be? Yes. It's one of those, particularly at follow-up, of just checking, is the presentation kind of progressing as you expect it would be? Is there anything new that the patient might not necessarily come through and tell you? I got bitten about 12 months ago now with somebody who I saw in private practice with elbow pain, come through to see me, and in all intensive purposes, it looked like a proximal radial ulnar joint arthritis. Now, they're not overly common, but it seemed to kind of fit the picture. He had pain of the lateral elbow. It was clicking. It would lock into pronation when he was turning a key. And he's come to see me. He's come through from his GP. It had an X-ray. An X-ray, yeah, an X-ray, and it was reported as some mild OA in the proximal radial ulnar joint. The GP had injected it, and he was actually about 70% better. He'd seen a previous visit before that, and he wanted to come and see me because he was concerned about the clicking. And I'm sitting there, checked his past medical history, any concerns, any problems. In all intensive purposes, he was quite fit and well. I think he was on a preventative statin. And I suppose I was probably a bit reassured by the fact that he had a normal X-ray. So I was treating him for his elbow, and probably after about 3 or 4 sessions, he just wasn't getting any better, and this clicking now had become a little bit more painful. He started to lose a bit of supination, and it just wasn't quite fitting with what I kind of expected to happen. Sitting down with him then and saying, I kind of just said what I said to you, it's not really progressing. Where do we go from here? We kind of decided to call it a day, and he asked me a question seemingly on the way out. It seems to always be the case with these presentations. Where he asked me about if I could prescribe him some medication, and I'm not a prescriber, but he took out his pocket some alendronic acid. And so you went on this a few sessions ago. He said, oh no, it's changed recently. And it turns out in between the 3rd session, the 4th session that I'd seen him, he'd had a fall. broken 2 pubic rami, ended up being seen in endocrinology, and was diagnosed with late onset hypergonadism and osteoporosis. So he'd been started on vitamin D, he'd been started on calcium, he'd been started on alendronic acid. So with that in mind, and I probably should give you a little bit, I probably missed a little bit out here in terms of how it came on. It came on about 12 months previously lifting a box, seemingly insidious, and then you develop with this lateral elbow pain. So I expected, so actually this changes things a little bit, because we've got a bit of a mechanism. You were lifting a box which was heavier than usual. There's immediate onset of symptoms. You've lost some movement. You've got some mechanical signs. We've got an X-ray which shows mild arthritic change, which probably doesn't correlate too much with the picture. So we arranged for this chap to have an MRI scan. And when the MRI scan came back, it actually had an insufficiency fracture of his radial head. And that just shows me really, if I hadn't asked him on his second time when he came back, or his third time when he came back, anything changed. He hadn't even told me he'd fractured his pelvis, which, if someone comes through, and particularly an elderly gentleman with a pubic rami fracture, you're already starting to thinking about kind of fragility and insufficiency fracture. So as soon as he started talking, again, seemingly on the way out, my index suspicion pricked up, and I thought, actually, I think I might miss something here. And considering that he had his elbow injected prior to seeing me, we've also put steroid into a fracture. Thankfully, he ended up doing okay. But it just goes to show a couple of things, really, and I think we might talk about this a bit later on, but the difficulties around private practice versus working in community MSK within an NHS service, but also just keeping that suspicion up, particularly when I look back on it, the pattern didn't really fit what I was treating in terms of what I thought was going on. But thankfully, then it all started to make sense when I did go back in to revisit some of the questions that I probably covered on the first session, but hadn't done until the person stopped getting better.
You wouldn't necessarily revisit them habitually, and especially in this circumstance, he could have continued to do okay and steady away. It was something that was manageable. It would have been easy to miss. So yeah, I'm glad you get that chance, and fair play for. I'm glad to hear of a positive outcome. What could have gone certainly wrong. Now let's linger there for a sec. Then let's stick with bone health, because it's. I think most people would recognise that if you were going to be especially suspicious of fragility fracture and just low bone density, etc., then you'd be looking at certain profiles of candidate, namely female, let's say menopausal, perimenopausal, and the elderly, in which they have decreased weight bearing, exercise, etc., and the profile that also exists with regards to the female athletic triad, with regards to amenorrhea and the concerns that can emerge from that. There's almost a typical pattern that, whilst we still need to be vigilant in that direction, don't get me wrong, from what I've gathered from us talking off air, you feel that sometimes we can be a little complacent in cases such as the one you've just described and others, where bone health can be a masquerading variable and a red flag that's often missed.
Absolutely, and I think this is something we're going to see more and more of, for a few reasons, really. We've got an older population, people living longer, and that's one risk factor in itself. But then if we look at the quality of the diet that we're eating, again, as a population, it's not as good. And probably the biggest variable for me really is physical activity. And as you say, whilst the elderly might not be doing weight-bearing activity, well, our adolescents aren't either, and our kids aren't either. And there's some good evidence that the amount of loading that the bone undergoes during adolescence is protective for kind of bone stress injuries and bone health in later life. So I think this is something which we're going to be seeing more and more of. And you're quite right. I think there is a typical profile which I suppose we're quite happy on the lookout for, and generally they are kind of two ends of the scale, like you mentioned, the female athlete triad, maybe in a kind of a younger population, but then we're talking about the kind of osteoporotic, usually female, usually kind of 65 and above. But then there's that kind of group in between that we're not too vigilant of. Now, in relation to NICE guidelines, for example, in relation to bone health, It talks about kind of suggesting or being vigilant of fracture risk or assessment of fracture risk in people over the age of 65 if they're female, over 75 if they're male, but also things like alcohol intake. So if you're going above the national guidelines in alcohol intake of 14 units for women, 21 for men, for low BMI, smoking, even a family history of hip fracture has been shown to be a risk factor for kind of insufficiency or fragility fractures in the future. But then alongside that, maybe a bit more of the subtle presentations. So for me, in terms of my reasoning around red flags, it starts before I meet the patient. And particularly within my role with Connect, it starts before I meet the patient. So I'll get the referral open and I'll screen the past medical history and I'll screen the drug history so that I'm starting to look for things that might just made me think about certain presentations, or might make me think, right, as part of my assessment, I've got to be clear that I don't think that's at play. And it might be something that is termed kind of systems thinking. If someone comes through and they've got, I don't know, they're on a statin, antihypertensives, they're on an anti-cholesterol, and they've got a history of MI and cabbage, I'm already thinking, right, I need to be mindful of the vascular system. And for bone health, I'm looking at things like COPD, are they on kind of oral steroids, prednisolone? Have they got a history of Crohn's? Have they got an underlying rheumatological condition? Have they got a spondyloarthropathy? All these things that might make me think, well, actually, these could be indicators of a low bone mineral density. Or sometimes picking up certain things like ladies that have had hysterectomies relatively young, so maybe like kind of below the age of 45. We know there's a link there with osteoporosis later in life. So it's not just those people that come through that elderly or been diagnosed with osteoporosis that I think we need to be mindful of in terms of patients presenting with potential bone health issues.
Yeah, for sure. No, that makes sense. Now it does. I don't have to do much of a segue to considering the ways in which, especially bony tumours, will. Sometimes some of the indications is a deeper, what could be considered a bone pain, or sometimes the fact that we don't necessarily discover someone's cancer until they become pathological fractures and the consequences of them. So, like I say, it's an easy segue because there is sort of a natural link there where they're not often separate. They're in the same thing. So in terms of what are signs and what's the data tell us, and the is it more about, are we having to rely on this pattern that emerges in clinical hunch, or are there some go-to things that we can be more accurate on with regards to cancer, both in terms of primaries and metastases?
I'll say not really, to be honest.
We'll move on then.
So this is the interesting thing around cancers. We know that kind of the biggest or the most sensitive or the most predictive kind of red flag is naturally a past medical history of cancer. But as you quite rightly say, sometimes things like prostate cancer, for example, even with, if it's localized prostate cancer, even if it's advanced, can sometimes be completely symptom-free until they start to develop secondary mets, and it's the mets then that pick up the primary or the unknown primary. And some of the literature, well, most literature always tells us that early detection is better. Early detection is vital, improves prognosis, it's easier to treat. But then there's not much guidance in relation to how to pick these up earlier. There's a lot of talk around pain, and particularly in relation to the spine, night pain. But even that's open to interpretation, really. There's a paper that came out this week in the Journal of Bone and Joint Surgery, which showed that there can be a false positive of night pain up to 96% of people. And that came down to the definition of night pain. So there is a bit of inconsistency. It's probably a bit of a side note in terms of how the red flags are defined anyway. So if we're not clearly defined the red flag, we're not all speaking from the same hymn sheet as clinicians, therefore we haven't really got the guidance. Now that's one angle for it. The other angle is actually you can see it as a positive. If we're not too specific about red flag, that might minimize the algorithmic nature and actually promote reasoning. But I agree, we probably need a little bit of better guidance. And I suppose really it comes down to which type of cancer. For example, if we're looking at prostate cancer, for example, we might not necessarily be thinking someone might come through with hip pain or kind of low back pain. And when you're asking your questions around bladder, bowel, there's kind of lower urinary tract signs which might pick your kind of your ears a little bit in relation to the potential for this being a cancer. Because if you even look at metastatic spinal cord compression, a quarter of patients diagnosed with metastatic spinal cord compression don't have a primary cancer at the time of diagnosis. So maybe a little being a bit aware with how certain cancers present, it could be quite useful. And I think particularly as this talk around first contact roles, we can learn a lot from GPs. So we can learn a lot from terms of consultation methods. We can learn a lot from GPs in terms of systems thinking. They do it on a daily basis. But we might have to start getting a little bit more familiar with the early signs and symptoms of certain cancers, as opposed to the early signs and symptoms of when the kind of joint pain or the bone pain is presenting, and trying to pick that up as a cancer, if that makes sense.
Mm-hmm. Yeah.
So, for example, if we're thinking prostate cancer, I know from speaking to you off air, you've had a similar experience in relation to prostate cancer, in picking up those subtle lower urinary tract signs. So a change in frequency, a change in urgency. There might be some level of kind of dribbling or passing urine, erectile dysfunction. But all of those could potentially be red herrings for chloroquine. So this is where then, like, we go right back full circle. The algorithmic approach to reasoning kind of falls down, where we might have to start to contextualize and say, well, are these symptoms related to this benign prostate hypertrophy, or they're related to something a little bit more nasty? Either way, that person probably doesn't need to be sitting in front of you at that time.
Yeah, for sure. I think one of the difficulties with cancer, and I've found it. I'm constantly trying to adjust the way in which I teach it, but I don't think I've been able to do it well recently, where I don't scare the living daylights out of especially new graduates and students that might be present, where essentially people like to consider, and I remember I did, that when cancer presentations turn up, then you've got this gaunt, ill, shivering person that's lost a certain amount of weight over a certain amount of time, that's got specifically non-mechanical pain. But unfortunately, tumours are space-occupying lesions, and they can masquerade very well as certain things, and they don't necessarily have to have unremitting symptoms. They can behave very mechanically. The circumstance that you're describing, that I've mentioned to you before about the prostate, was a real turning point for me in terms of scaling up my medical reasoning and spending more time with APPs. Was that, yes, maybe if I'd have had a chance to question in more detail and had more knowledge over straining to pass water and some of the frequency changes, then perhaps it wouldn't have taken for me to be suspicious of stenosis and not happy with some worsening leg symptoms, and organised a scan that then unveiled a very cancerous spine, for want of a better term. I reflected heavily on that process, in which really I was unfairly, to some degree, applauded for the fact that we detected it, because sort of my gut I wasn't happy with it, even though his symptoms, back pain, had been doing well, but then developed some leg symptoms. I wasn't best pleased with how they were behaving. My gut sensor went off, but essentially I did not anticipate what we were going to find. And so when I reflected on it, perhaps weeks earlier, I could have probed a bit deeper into understanding the symptoms and knowing about the cancers. But that comes to the next question, really, is can you explain to the listeners a little bit about how the type of cancer and location of cancer that someone might have, bearing in mind that a lot of this would be unbeknown to them, otherwise it would make our job a lot easier, but let's say that they've got a primary somewhere. When we're spinal and peripherally, what are the cancers that we're going to be most concerned about?
Absolutely. I'm all right to go just back a second, if that's all right. And it was just something you kind of alluded to. And it's probably one of the reasons why it's really important that we do reevaluate the patients over time, like we mentioned previously, because they often do present very mechanically and very much like a musculoskeletal presentation in their first instance. That's just the nature of the beast. It's probably one of the reasons why they can be missed, or there is often a sufficient delay to diagnosis. But on the same token, similar to what I mentioned in relation to bone health, we've got an aging population. And we're getting better at treating primary cancers. So the incidence or the rate at which we're going to be interacting with serious pathology is probably going to go up in musculoskeletal practice. Mm-hmm. People living longer, we're treating it better, and therefore there's a greater likelihood that they're going to develop secondary mets and end up presenting in our clinics to us. So I suppose there is probably a mandate there for us to upskill our kind of medical knowledge, so to speak. So we can start picking these patients up a little bit earlier. What was the next question, Jack? Sorry, I kind of went backwards a little bit.
Inviting you to comment on the why types of cancer matter, and sort of the certain types, certain primaries that are more prone to metastatic behaviour.
I see. Okay. Well, again, most of the kind of what we know about this often refers to the spine, but generally to the kind of the reason for that really is because of the bone generally. Like your big three really are kind of your breast, prostate, and lung that you're most likely to metastasize. And I suppose this comes back to them how we talked about past medical history being used as a bit of a blunt tool, because it does depend on the type of cancer, how long ago it was, how aggressive it was, how it was treated, in relation to how much you weight it in terms of your reasoning. So I suppose it's important to be aware of the relative risk of certain types of cancers metastasizing, but also those that do have an affinity to the bone, or do have affinity to the spine, kind of in particular, really. So, for example, we know that breast cancer likely has metastatic relative risk of about 30%. Prostate, surprisingly, about 1 in 2. It's about 50% are likely to go on to develop metastases. Lungs about 36%. And then we've got thyroid cancer about 4%, and kidney about 6%. And those are the ones that have an affinity to spine, have an affinity to bone. So you probably want to weight those a little bit higher. But then if we think about something like liver cancer, the relative risk of that metastasizing is about 14%, but doesn't have as strong affinity to bone. So if someone comes through with kidney cancer, although the relative risk of that metastasizing is 6% and liver 14%, I'd probably weight the kidney, previous history of kidney cancer, I'd weight that stronger in terms of my reasoning than I would with somebody with liver cancer, just because of the relative risk and the affinity to bone and affinity to the spine, if that makes sense.
Yeah, it does, absolutely. And as you say, these are sorts of things that people are finding ways to live with them in remission with medical help, and there are various conditions in which we're going to encounter more in people that consider themselves well as well. And that's one of the things that's interesting, is that sometimes you might find yourself probing into someone's medical history and them detailing something that you can't believe wasn't super forthcoming, such as the amount of people living with HIV that is otherwise manageable. Cancer has been the one we're talking about now, but there's lots of conditions that are medically well managed to the point in which they're not as tethered to someone's identity as they might have been historically, when there were things that were disabling them on a day-to-day basis. And so it's certainly something to, again, remain vigilant for.
Absolutely. And I suppose it kind of drops off the radar a little bit, and particularly kind of over, as you say, over time. In most cancers, in terms of kind of low-grade lesions, they're likely to kind of metastasize within about 2 to 5 years after onset. But that's kind of a general rule of thumb. I think if someone comes through with a malignant history of cancer, it should make you sit up a little bit in relation to your index should go up and your threshold should go down a little bit. I wouldn't base my decision to either further investigate or refer on based upon that one piece of information, but I'll definitely feed it into my reasoning process. But I suppose it's probably a nice point to mention that, particularly if you have got a metastatic deposit in the spine, is most likely going to land in the thoracic spine. It's about 70% will land about the thoracic spine, 20% lumbar, and 10% in the cervical. But where the person feels the pain, or the sensory level of the symptoms, may not correlate with where the metastatic deposit is. So if you do have a patient that you're thinking, like, they've got spinal pain, past medical history of cancer, I'm suspicious that this might be metastatic. It's not just about scanning the area of symptoms, it's about scanning the whole spine and making sure you're doing an appropriate survey to pick it up. The most recent spinal metastatic case I've seen actually had come to see us with a lumbar spine MRI because I had low back pain, and it kind of falsely reassures you. But it was seen quite clear that the symptoms didn't fit. And it wasn't my patient, it was a colleague's patient, but following a discussion, a whole MRI scan, a whole spine MRI, soon revealed that there were quite significant metastatic deposits.
Absolutely. Unfortunately, it's some years ago now, and certainly I think practice is better in this direction now, as there's a proliferation and improved access as well for radiology, for physios particularly. But there's been times where someone's presented with, and in this case wasn't cancer, but what's behaving like a strange compressive lesion. And so it's right. With lower limb symptoms, lumbar spine MR clear, still bizarre, not responding, don't make sense. Thoracic MR, it's clear, not responding, and eventually then a lower cervical lesion is found that's sort of central and is affecting things at the lower limb, and it's just sort of like, well, that could have been avoided with not just good reasoning, but also just decent protocols for what we were looking for, and so yeah, I totally agree with that, and something absolutely to bear in mind, that we need to make sure we zoom out sensibly. We don't want one view too few is the line that Paula Deakins hammered into me when I was being certainly trained up in this direction. So
that's a nice way of thinking. I might steal that.
Say again, sorry. You like that
so
line?
That's a nice way of thinking of it. I might have to chat with Paula, but I'll run it past her first. But I suppose that from you just kind of made me reflect upon something there. And when you asked me about what things am I on the lookout for within MSK practice, and again, I probably fall into a trap which I kind of try and teach against. It is around kind of infection as a space occupying lesion. And often, with infections being relatively rare and quite a significant delay to diagnosis, they're often picked up incidentally when someone is considering some form of cord compression or some form of unbeknown space-occupying lesion. It will turn out to be a kind of an infection. I don't know if that's kind of similar in terms of your experience locally, but I myself personally, I've not had a spinal infection in my place of work or in my clinic or any of my colleagues that I'm aware of, purely because they're rare in the UK, but the actual kind of I suppose we've probably seen some, might have missed them, is because the signs and symptoms of the spinal infection just lack such specificity that unless with quite a acute vigilance, they're really hard to detect and really hard to pick up.
Yeah, I mean, I'm racking my brain as to whether I've got other examples. I did pick up a case of TB when I worked in Nottingham City from someone, but it was fairly I admit it was a bit of a penalty kick with regards to the recent foreign travel and the way in which things were behaving. That's the only thing nearest to it, but obviously it's not the sort of infection you're describing. One of the things, I had a colleague that had a case of spinal infection that's along the lines that you're describing, in which it was masquerading more as the concern wasn't necessarily over infection as it was sort of a demyelinating sort of neurological lesion, perhaps, and that was how it was behaving. So they were concerned and acted appropriately, but it turned out that it was it was secondary to infection. So that's the only sort of thing I can think of at the top of my head. But I agree, because of the relative rare aspect of it, certainly spinally, whereas but infection generally influencing musculoskeletal pathology, that's something that is less rare. We can comprehend that. Certainly in a sporting context, we see that a little more, and certainly soft tissue infections that can then start to influence pathology.
Yeah, you're quite right. And again, it's something I kind of drive home to kind of the junior staff when we are teaching on this, is that particularly in the periphery, or any form of infection, but particularly in the periphery, it's probably a little bit easier to pick up. Is there's got to be a route in, so there's got to be a way in for the infection.
So you should examine every orifice every time. Is that what you tell your junior staff? Is that the prank?
That's my practice.
That's the prank.
But yeah, absolutely. But I suppose then again, obviously, there's got to be a route in, and you're quite right. I think we're well versed in questioning regarding recent foreign travel, recent kind of insect bites or things like that. But sometimes it could be things again that drop off the radar of the patient. Have you been to any other professional recently? Have you been to the dentist? I might have had a tooth abscess and then gone on to develop some kind of joint pain and not made that link together. And it could just be a complete, as you say, kind of complete red herring. But it's important then to sometimes if things aren't making sense, to maybe go that little bit further with the questioning, particularly if someone is at a higher relative risk of developing infections. So whether they are kind of immunocompromised, as you mentioned, if they're living with HIV, they've got a history of kind of intravenous drug use, if they're they kind of one thing we see a lot in West Yorkshire is kind of non-medical injections from potential gym goers, and again that's quite a big flag there for potential infective pathology, but also. And one thing that again has come off my radar a little bit, I was teaching out in India last year, and I was teaching about spinal infections. And I kind of went into kind of robot mode and completely forgot that the incidence of spinal infections or any form of joint infections in India is naturally going to be a lot higher than it is in England. And I kind of just talked about infections like I normally would. In the spine, the UTI is probably the most common route in. And this chap put his hand up and said, actually, no, for us here, we see a lot of spinal infections. And they could tell me a lot more about how a spinal infection it typically presents than I could about them. I could to them in relation to, in terms of my teaching. But it was really this kind of learning perspective from that regard. And particularly kind of in the UK, the majority of spinal infections, in particular in the spine, will be either a UTI or post-spinal surgery. And again, this might be one of the reasons why I don't see too many in my practice. I don't see too many post-op spines. But I think, if you are seeing kind of a post-op spinal caseload, when you're checking the wound, I can't really kind of stress that enough in terms of you've got a direct route in there for potential for infection.
Absolutely, no, it's a great point for sure. And again, much like I described this textbook stereotypical case that never happens, where someone walks in sort of shivering, gaunt, and losing weight rapidly. This similar sort of feverish person that's coming in with an infection, whilst occasional, it's rare, and usually it's something a little more subtle than that. So yeah, bites, wounds, points of excess, especially those in the sporting sector, increasing proliferation of recreational combat sports. So looking out for things like strep and other rashes and issues with that from close contact that we used to see more of in rugby, but we're seeing it lots in combat sports as well, as that increases in its popularity. So certainly remaining vigilant for that is super important. If it's okay with you, I want to wade us into a couple of case studies that I've just bundled together, and we'll sort of tweak the variables as we discussed, just because I think that this we've tried to demonstrate that we're just sort of reasoning and telling tales and stories because we're trying to move away from, because the evidence guides us away from any algorithmic model. So if you've tuned in, you've got this far, and you're still expecting you've got your pen in hand waiting for us to tell you which red flags are the ones you need to ask in the morning, you're going to be disappointed. We're going to walk through a reasoning process with some case studies, much like we've done so far. And so in that spirit, I wanted to walk into a couple of case studies, so which of course I've made up, so no rights and wrongs here. But essentially, if we're describing a 65-year-old male with axial low back pain for 10 years, which is worsened in the recent months, so say last 3 months, and it just feels different, is how they're describing it. There's a negative neuro on objective testing. It moves well, but it aggravates in the last third of all ranges, so there's no real directional preference. It's all a bit sore, certainly prefers to be in neutral. He's got a history of cancer treated successfully 5 years ago. And so essentially I've purposely not put a name to what. So in that story, if that was described in that part in a referral, where are you going with that straight out the gates?
Absolutely. So I suppose if I break down almost like from a reasoning perspective again, really, 65-year-old male. Historically, when you kind of your hierarchical red flags, you would weight that as being a red flag, or over the age of 50 being quite a considerable red flag. For me, in that regard, 65-year-old male, that's not neither here nor there in terms of my reasoning process. I'm aware of it, but I think as we're getting older, 50 is essentially the new middle-aged. But also the important piece of information there for me is if it was 65 and first episode of low back pain, that's completely different. But I think, actual low back pain for 10 years and 65, okay, I'm with it so far. But what I really want to explore is around the worst thing in the last 3 months. And my initial reasoning process really is, well, just tell me a little bit about what was going on in that 3 months. So I'm not necessarily going down a serious pathology route at this point, but thinking, was there a mechanism of injury? Was there a trauma? Was there a trigger? Is there something that kind of fits and makes sense? And that's not, in the realms of serious pathology, that's not kind of clear cut. But again, it's part of that reasoning process. Is this kind of a mechanical low back pain? But also then from a practicing or well versed in the biopsychosocial approach, I want to know what else was going on in that 3 month period. So how are they sleeping? Were they stressed? What was going on in terms of their lifestyle? Negative neurology, fantastic. The nerves are conducting well. That's always reassuring. And the fact they're moving quite well with, without a directional preference, generally, a bit painful, but not too untoward. But then I really prick up when you tell me about the history of cancer 5 years ago. So what am I thinking there? I'm thinking, I know history of cancer is the most predictive red flag. 5 years ago, it's in that chance of kind of likelihood to metastasize. So in my questioning there is going to go down, well, what type of cancer? How was it treated? How aggressive was it? And are you still under surveillance? Are you still under the oncologist? So looking at a bit of information around there at that period of time. So my index of suspicions perked up, my threshold's gone down. I wouldn't be making any decisions just off the basis of that information there.
So we can add some weight to that then. Let's say that this worsening has been insidious and somewhat surprising to the patient. They've not really felt it be like this before when they've had flare-ups. It doesn't seem to make sense to them, and a lot of the tactics they've used historically to settle something down hasn't helped. And the cancer was prostate cancer, treated with radiotherapy successfully and stabilised, and each annual review since then has just been lower and lower PSAs, but the last one that they had was, he is sort of due one, let's say is about 10 months, or you couldn't make a case that he might even have been discharged, but for the sake of it, let's say he's still under oncology but under very infrequent review. So how does that influence things? Is that reassuring, or is that something that would sort of direct your decision making?
There's a couple of things there, really. So again, prostate, like I mentioned before, it's got about a 50% relative risk of metastasizing, and we know it's got affinity to bone, and know it's got affinity to the spine. You can fall on the trap of false reassurance with oncology reviews, because a MET can come back at any time, and 10 months is a relatively long period of time. But here in this kind of case study, for example, with that information, I'm probably thinking this is somebody who I might not necessarily make a decision one way or the other at the first time I've met them. I would probably suggest contact with the oncologist or chasing to find out when the next review is going to be. I would probably look at questioning around those subtle prostate signs that we talked about previously. And I'd probably safety netting in terms of some signs and symptoms to work out for. So like I mentioned earlier on, in terms of the work that Sue Greenhouse Group done in terms of metastatic spinal cord compression, he's somebody that I leave my consultation room without one of those little credit cards, being aware of the signs and symptoms and knowing what actions to do should they develop. But he'd be one that I'd probably want to keep an eye on. I'd probably refer in for some rehabilitation to see if we can settle it down. But I'd be reevaluating and making sure that he knows what we're thinking, what we're doing, but also that he has a communication back into the service. So if things do change, or if he does need a bit of support, then he knows where we are and he knows what to do to discuss that, ensure that things aren't going potentially in a serious direction.
Yeah, and so he hasn't necessarily met your threshold for imaging at that point in time, is what you're saying, as it stands. But if I was to, are you suggesting that it wouldn't take much to tip it over the other way? So if you were to have some strain in passing water and some features that he hasn't declared to any medical professional recently, where he is starting to notice erectile dysfunction or other sort of clues that we discussed earlier, would that be sufficient for you to then investigate?
Again, in the hypothetical case study, it would, and I think often it is that subtle change which can contribute to the later diagnosis. So even if from, maybe away from the prostate, but even if you come in to say that I'm just not walking quite right, or a family member might notice that occasionally he limps, and it might just be quite subtle, it might not necessarily be consistent, because like we said, we know with these patterns, they don't have a complete deterioration or linear deterioration. They often do wax and wane. I'm just looking for, do things change and do things fit? And if you did start noticing just those subtle signs, then yeah, my index of suspicion is raised, my threshold's lowered. But off the basis of as where we were at current, it's somebody I really value the role of safety netting, and I suppose it's something that I'm quite lucky within Connect, that I have a short waiting list. I have the opportunity to review patients. Well, I know not everybody in advanced practice clinics do. And if you do only get one contact, I can see why people would investigate off the basis of the information we've got here. We know that some services up and down the country, their pathway, their protocol is a history of cancer scan, which I don't necessarily think is correct. But whenever we talk about reasoning, it's always important to consider the kind of the governance around the service that you work in, the specification of the service, the time you've got available, and the constraints and resources you've got available, because they will impact upon decision making. So I'm quite lucky there with the example you've given me, that I can watch for weight, I can safety net and keep an eye over time. If I didn't have that, maybe my reasoning would be slightly different.
And especially that watchful waiting, safety netting, call it what you will, alongside a sensible, informed discussion with the patient about what they're looking out for, can be a really useful thing, especially if you've got an accessible service in which you can give reliable phone numbers to, and in a patient that's going to be sensible about it, which we can also sort of screen for in a sense. There's certain times where you might need to take the responsibility where a patient isn't necessarily comprehending what you're getting at, and there are times where just the context of that specific patient, that individual's making you think, right, in other circumstances, even with the same objective and subjective information, if it doesn't map onto their circumstances well, then sometimes that might influence it as well, or at least I might be projecting there, but it does for me.
Absolutely, and it's that gut instinct, isn't it? It's that intuition based in reasoning. Going right full circle. It's that pattern of something doesn't feel quite right, and you might not necessarily be able to say what, but some of the languages work around intuition, around gut instinct. They're very much reasoning processes, and when you do have that mileage, so call it pattern recognition, call it what you will, and it could be pattern recognition where this doesn't fit musculoskeletal. And I've got a lot of patterns in my mind which I know what musculoskeletal looks like, and I think as physios we're pretty good at that, and this might not fit that framework. Or it could be, do you know what, I've done lots of miles in the APP clinic, I know when things that are serious present, this fits that pattern, and you might not be able to maybe even verbalize what it is, but I'm a big believer in gut instinct and in reasoning. And you're quite right, you might not necessarily put your finger on it, but something doesn't smell quite right, and then investigate appropriately.
Let's just tweak the dials a little bit on that before I move on to the other one, which I think will be a bit briefer. But let's say then the history of cancer was a few months ago, developed a bit of a melanoma after a period of time on the Costa del Sol, where maybe overdid it on the old sunbeds. And essentially that was successfully treated. They did a biopsy and then removed a sort of nasty looking sort of, what am I looking for? Wart, is that the right term, or sort of a skin
Sort of
tag of
legion.
some sort? Yeah,
Yeah.
some sort of skin lesion, and that was removed. There was certainly no evidence of any skewing of any blood tests and things like that. So in that circumstance, the only dial we've tweaked is the actual type of cancer, and that would be something that where, sorry to put words in your mouth, but just correct me if needs be, that would be a circumstance in which it would indicate certainly that you would proceed in this circumstance with watchful waiting and just monitoring whether that is happening, and you would be less concerned over that individual relative to the prostate cancer example.
Yeah, no, I agree. And again, it comes down to, like you say, it's taking that history of cancer just a little bit further along and saying, well, in terms of the context of the presentation, how much do I weight it? And I would weight that a little bit lower. So yeah, you're quite right. My management plan probably not too dissimilar, but maybe I wouldn't keep as close an eye on them as I would in the aforementioned example.
Sure. And then let me sort of make it, let's say he hasn't got a personal history of cancer, but a close family history of lung cancer. How do you, we haven't really touched on that in terms of the hereditary nature of these sorts of things.
Yeah. In terms of if it was a lung cancer, I'd probably have to say that I'm not overly clued up on the hereditary link in lung cancer. If I changed it to a female and breast cancer, because I can answer that a little bit better, then I'd weight that. Because the thing with lung cancer, you're looking more for, well, no, not exclusively, but you're looking more for other kind of exposures to carcinogens. So whether that be a smoker, whether that be somebody, particularly in Yorkshire, that worked down into the pit, for example. Whereas if it was a female with a strong family history of breast cancer through mother, grandparent, sister, etc., then yeah, for sure, I'll be weighting the family history in a lot more detail, as well as asking and being familiar with asking kind of follow-up questions to that in relation to how early breast cancers might present. So, I think most people are quite comfortable in relation if you checked yourself for lumps recently, but you might even need to go in a bit more detail. So, has there been a change in terms of lump in the axilla? Has there been changes in kind of nipple shape, particularly if the person's over the age of 50? Has there been changes in terms of the skin of the breast, which might not necessarily prick the attention of the patient, because they might just be looking for a lump and think, well, actually, I'm not quite sure that is something I've got to be concerned or worried about. But yeah, I probably can answer it from a lung cancer perspective.
Yeah, no, it's fair enough, and that's how I understand it as well. It's certainly less of a hereditary link there compared to breast, but similarly, in this circumstance, I didn't want to give this chap breast cancer straight away. Of course, it can happen, but rarer.
Yeah,
so let me then walk into this second case study, which will cover a little more similar ground, but there's a bit of a difference as well. 30-year-old female with hip pain for 6 months. It's activity dependent, so he's behaving mechanically, and she's describing it as such. But she does have some night pain. It sort of throbs overnight, and it's difficult getting off to sleep. Sometimes does wake her. Sort of guarding of the hip on assessment, not really letting go of it very easily. Unable to run at the moment. She got a low BMI. Bit of a compulsive exerciser by her own admissions, and some compulsive eating habits as well. Not described as disorder by the patient, but sort of on probing. It's shown to be such. She's quite vigilant in that direction, so to speak. And so, in this circumstance, is there anything that sort of flares your thinking? And just talk us through this one as you did the last.
Yeah, absolutely. So again, I'm going to go for what my kind of knee-jerk reaction is in relation to what I think could be going on, but then we could have a very similar kind of discussion around kind of types of cancer in this age group. But interestingly, again, if I'm thinking about weighting of these historically hierarchical red flags, somebody who's 30 naturally should be weighted 0 in that system. So I'm looking at activity dependent. So there seems to be a form of mechanical pattern. I want to know, has that pattern changed, for example, in terms of irritability? So had the symptoms become easier to provoke? Have they taken longer to provoke or longer to settle? And that would certainly seem to be the case in relation to being unable to run. We're looking at the night pain side of things. And night pain is an interesting one. There's lots of well, there's a lack of consensus in terms of which red flags we use for which pathology, and night pain seems to come up in a hell of a lot of them. And like I said, that recent paper in the Journal of Bone and Joint Surgery showed that there was a false positive rate around night pain for about 96%. So in relation to night pain, I need to know a little bit more detail around it. So is that mechanical night pain? So she could, for example, be a gluteal tendinopathy that just doesn't like laying on that side. But if she gets onto the other side of the hip, she can usually settle. So I want to know, can she settle? Or is she somebody that has to sleep upright, sleep out in a chair, is getting up at ungodly hours, walking the house, having a cup of tea because they just can't settle? And that to me is what would consist in a kind of an unremitting picture. That's not normal mechanical night pain in my reasoning. So we're then thinking of kind of guarding the hip. So I'm getting some indication this is probably quite an irritable presentation. But then you really hit the three bits of information that kind of prick my ears, really, in relation to potential for that female athlete triad. So we know from some pretty convincing research now, there was a systematic review in BMJ a few years ago, I think 2012, by a chap called Pegram, which showed that patients with a female athlete triad were at a higher risk of bone stress injury. So similar to what I kind of spoke to about earlier. And this, for those that aren't familiar with the female athlete triad, is essentially this interrelationship of menstrual dysfunction, reduced bone mineral density, but also the kind of the central factor in this triad really is that low energy availability. And that can be through expending more energy than taking in by doing a lot of activity, or it could be expending more energy than taking in because of poor eating habits. Now, it might not be a formal eating disorder per se, but there might be, as you quite right say, there might be some form of restricted or quite compulsive eating, but not necessarily a formal eating disorder. And the reason why that appears to predispose to kind of bone stress injury is there's a reduction in the ability of the bone to both resist load, but also to impair the ability of the bone to repair to the stress being put across it. So that's what I'm kind of looking at in terms of my thinking at the moment.
One of the dials I wanted to tweak to answer some of the questions was, let's say this patient is someone that when they're more active, they're struggling with the hip pain, and it's a sharp pain with impact, especially if she keeps attempting to run or to do anything, or she sort of trips over and sort of stumbles off a curb or something, and it gets quite a sharp pain through the hip. But then it's more to do with the more that she's walked on it. The night pain is actually just sort of a low grade throbbing that doesn't seem to matter what position she's in, and it does eventually settle and she does eventually get off to sleep, but it doesn't necessarily matter as to what position she's in. It's just this sort of deep aching and throbbing when at rest. I can't remember if you had any other sort of questions that you wanted to lay on there.
And particularly for this kind of population, like I mentioned in terms of the triad, there is the kind of the factor relation to kind of menstrual dysfunction, or the amenorrhea. I'm very good at pronouncing it. So my questioning would go down that kind of the women's health route really, around that. And I might be asking some questions around medications. For example, is she on the combined oral contraceptive pill, which might lead to some period disturbance? But I'd also be wanting to screen for potential kind of cervical cancer involvement. So any kind of vaginal symptoms, any bleeding, discharge. Does she have pain when she passes urine? Does she have pain during sex? Is there kind of global pelvic pain, or are we quite localized to the hip here? So part of my screening process, particularly in a lady who is 30 and if, let's assume, is sexually active, that would be something on my radar, just to kind of screen through. And you're quite right in relation to if this patient walked into my community MSK clinic, I'm quite lucky that I work on the same corridor as a very good SEM doctor, and I'll be definitely having a chat with him about this kind of this presentation, just to get that bit more of a medical kind of viewpoint around potentially the women's health side of things.
Yeah, for sure. So in this circumstance, with sort of you've investigated sort of young tumour features in a sense as to what might be happening. Let's suggest then that this is something that could well be a bit of an insufficiency fracture. Let's say just be either bony stress, or potentially us having concerns over it maybe being a pathological fracture at the neck of femur, for example. Would you be in a situation here where it is within a niche that you would want to refer that to sport and exercise orthopedics or even orthopedics itself, or is it something that you'd want to do the workup and potentially keep it in-house?
Obviously, again, this is where, similar to the previous example, it very much will depend upon your service, your specification, your pathways. For this lady in particular, I would probably look at doing an MRI scan, particularly as it's the most sensitive and kind of specific investigation for picking up insufficiency fractures. But I would definitely be having a conversation purely because of access to me really in community MSK, of having an SEM gypsy. And in terms of my reasoning, thinking this does sound like a bone stress injury from that female athlete triad, whether that be through poor training load, whether that be because of the other risk factors we've mentioned. My bias in terms of our service and our structure would be discussing this and be able to get an SEM input. But naturally, that would then depend on what came back out of it. If it came back and it showed that it was a stress fracture, I think within physiotherapy and with the SEM input, this can be managed conservatively, a period of offloading and gradual reloading. But if it did show that there was a kind of a pathological fracture there, then I would probably suspect this would be something that would go on to have a chat with an orthopedic consultant. So it kind of depends a little bit on the kind of the intricacies of the case study, which I know you don't really get in these scenarios. But it would definitely be one that I'd be having some SEM input because they're just down the corridor from me.
Yeah, absolutely. Now, if we were to look at some of the front end of the case study and tweak those dials a little, if this was a 50-year-old female, does that change anything significantly for you?
A little bit. I'd still be asking similar questions, like I mentioned previously, in terms of bone health, and I'd probably still be asking some questions from a women's health perspective, because whilst cervical cancer might be reduced, there is a greater risk of the ovarian cancer. And again, from working with women's health physios previously, they're concerned about the lack of vigilance around ovarian cancer. So I'd probably ask very similar questions in that regard. But I wouldn't be suspecting too dissimilar outcome, whether that be either a bone health issue from an insufficiency problem, particularly with the active history, and an increase in age. But there also could be, again, some other tumour features.
So what do you feel is the appropriate response when a clinician suspects serious pathology and would like a second opinion medically? Because as we sort of talked about right at the top of the show, is that we want to make sure we're getting the balance right between not being too haphazard with referrals, but equally making sure that we act appropriately and concisely. So what's your sort of take on that?
Absolutely, and this is something that since moving into kind of the kind of more the leadership aspect to my role recently with InConnect, it's something I've thought more and more of. And one thing I kind of really wanted to start off with is, I've probably already alluded to it, is that my reasoning process starts when I receive the referral. So when I'm reading through and I'm seeing the past medical history and the drug history, it gives me a lot of information about that person walking through the door. And I suppose, again, it comes back to the case that I gave earlier on the elbow. If you're not seeing this person within a kind of an NHS clinic or a community MSK clinic, and you're seeing them in private practice, there's an element of vulnerability from a governance perspective, from a pathway perspective, but also in terms of the information that you have to base your reasoning upon. Because we can ask, I'm sure you've been there, Jack, when you've asked a patient or tried to go through a past medical history. Oh, yeah, I'm fit and well, and you've got the referral in front of them, and the past medical history is as long as your arm. Mm-hmm. So you do rely upon some of them, the patient providing you the information. So I suppose that's something to be considered if you are working in private practice, is potentially finding ways of how you can gather the past medical history and drug history a bit more accurately, and building links within your local area to know your pathways and know your access. It leads us to a certain bit of kind of vulnerability, but also then can sometimes highlight the kind of, well, I wouldn't say the lack of, but potentially the difference in governance around the service or the setting that you're practicing in relation to kind of public versus private sector, if that makes sense.
Mm-hmm. Yeah, absolutely. And so something, let's say our case studies, we've turned both of them into situations in which we would like to bring it to the attention of our medical colleagues. Now let's take ourselves out of the APP hat
Yeah.
for a second and perceive that this is a primary care service in which it's been referred by GP or even self-referred, but essentially there isn't the capacity to then escalate that up. There's not, let's say there's not even been a significant workup possible, and it's just that the index of suspicion is high enough for us to want to bring it to the attention of the GP. Now, should that be a full essay and attachment of every patient record you've ever been in contact with, or is there a conciseness that you'd like to advocate?
Absolutely. So I think the key thing in there is to, if you're working as a practitioner or a physio and your index of suspicion is raised to a certain level where you're concerned, I think the first thing to do is just take a step back from the situation, because you can almost get a little bit engrossed and kind of caught up in it. It's take a step back, have a moment to think, pause, and ensure that decisions that are made might even not even be a clinical decision. It just ensures that it's one that maintains patient safety. So I think that's one thing to kind of to highlight. And again, in terms of the information then sent back to the GP or the process of sending back to the GP, I think it's important that the governance structure that you're working in is that you know your pathways, but also that the clinicians in that environment have gone through a set of competencies. So if you are putting such a scenario, it almost comes a little bit, it shouldn't be or what do I do now? It shouldn't be that question of, do I need to provide the whole letter and all the medical records or just a little bit of a note? It should be a case of almost, right, I've been put in this situation. I know from undertaking my competency training what to do in this situation. And within that, I think there's a kind of a real need for kind of peer support or discussing with senior colleagues or discussing with colleagues if you need it, just to ensure that the decision making is safe, but you're ensuring you're providing enough information for that patient to be seen by the right person along the right pathway. And that would be one thing I would really want to stress, is that unless you're comfortable and you've got the mileage behind you, and say taking the APP hat off a little bit, is just don't feel like you have to be making that decision by yourself. It should be one where you can go out, even saying to the patient, I just want to check a couple of things, I want to discuss with a colleague, and then come back in, have the communication, have the chat and get going. And if it is one potentially where, if you are safety netting, for example, it's really important that the patient knows the communication channel and are happy and they understand the plan and the next steps. So I think there's a big role, if I break that down to a bit of a summary, is that take a step back, think, discuss if you need to, but also ensure from a governance and organisational perspective that the pathways are in place, the clinicians know the pathways, and the competency training is such that if put in that situation, then you know what to do, and it shouldn't be something that's taking you back a little bit too much.
Absolutely, no, that makes sense. Now, you'd hope that process would mitigate some of the concerns that we might have by people too haphazardly sending back. Now, do you worry at all about a potential sort of being seen as being a hypochondriac profession, where GPs might be receiving sort of innocuous referrals back when really they need to crack on with some rehab? Is that a concern of yours, and have you any other tips of how to mitigate it if it is?
It's one where I've been thinking about this recently, because it's not something that I see too much of locally where I work. And I think that's quite lucky, because we have an open door policy in relation to colleagues, to staff members. And the idea is really, if you do have an element of suspicion, is just have that discussion. So it's not something I personally see too much, but I do think it's something that we run the risk of, and particularly if we are looking at going into self-referral or first contact roles, we want to be kind of demonstrating our value. And if our threshold is too low, and we're too vigilant or we're too algorithmic or not reasoning, then we do run the risk of actually duplicating a lot of work and not demonstrating the value that we provide to such positions.
Mm-hmm. And sometimes we do end up needing to make the case in a not necessarily a persuasive way, but we need to make sure that we're punctuating our sort of points in a manner that is going to make the GP understand exactly what we're getting at, rather than punting it back, saying very vague things. If there are things that you want to bring to their attention, then being able to word them in such a way that they know how to action that is another way in which we don't sort of end up with any interprofessional conflicts. I've certainly noticed, and also having made that mistake, as all listeners, regular listeners will know, I have a habit of waffling. Now, my original GP letters were certainly in that ilk, so I've certainly had to improve in that direction, and it's certainly a skill in itself to know just how much detail to give at any one time.
And I think what I'm probably adding there is that within your documentation, would be to me, as you're quite right, cut the waffle. It's a case of, I'm concerned by this feature, that feature, and this feature. And therefore, I would leave it a little bit open, because one of the things, particularly, I'm sure you get it, Jack, in terms of APP land or in physio land, if a referral comes in and it's prescriptive, we want X, Y, and Z, automatically you get your goat up a little bit. So for me, it's a case of saying, I'm concerned by this feature, that feature, this feature. I don't think these are consistent with a musculoskeletal presentation. I would value a medical opinion and appropriate further investigation. So keeping it quite broad, but highlighting what I'm concerned by and how I don't think it's a musculoskeletal presentation. But I'd also, kind of a bit of a caveat to that, something always sticks in my mind. I remember receiving a letter from a private physiotherapist that said, I feel this patient's got an inflammatory condition. Please, can you see them for an array of blood tests? And I always stuck in my mind thinking, well, an array of blood tests is quite a request. And if you're not quite sure of the detail, so if you're not quite sure what the most appropriate investigation is, I would probably steer clear of it. And even if you do know what the most appropriate investigation is, in the kind of aforementioned sentence, I'd probably still leave it a little bit open, but just make sure that what you're suspecting and what you're suspecting in terms of your reasoning is just clearly documented, but keeping it broad to allow the person you're referring into to make the decision that they think is best for that patient.
There'll be someone that you work with, or someone that you'll be able to at least get in contact with via us, via the internet, that will have been in situations where they've had their fingers burnt by wording something poorly. And if you've got no one that you can think of, then you can certainly reach out to us here, because we've all been there, where essentially you've made the mistake of sometimes being too dictatorial with what you've suggested in a letter, and that's then not helped warm a relationship between you and your local GPs, or you've been too vague, and similarly that's frustrated them, and they've picked the phone up in between clinics sort of saying, what are you getting at? And in both of those circumstances, the answer is to try and work out your wording, speak to colleagues, have someone run your letter by someone, and certainly if you've taken the time, as you've recommended there, Andrew, to pause and just give it a moment and run it by someone, then hopefully the sort of conciseness, I don't know if that's even a word, is going to improve. So yeah, I think we've certainly tidied that bit up, and it is very context specific when we're talking about such broad brush issues.
We talk about pathways and knowing your pathways, something which I think can sometimes get forgotten about, or if not forgotten about, definitely doesn't get discussed too much. It's just the importance of audit in such circumstances. And for an example of this, an ex-colleague of mine, a really good physio called Amy Robson, has just had some work published with NICE, where we looked at, we've got a pathway for metastatic core compression. It's written in relation to the NICE guidance, and that's great, but you shouldn't stop your governance processes there. It's important then that we audit, A, how well that pathway is working, but B, how well, as clinicians, we're adhering to it, because it's best practice for a reason. So having that audit cycle of, auditing compliance, working out how many situations may have deviated from the pathway, why they've deviated from it, and then putting necessary steps in place to prevent that. So whether that be training on the pathway for clinicians, part of the induction process, the competency frameworks, it might be worth about things kind of training identifying the condition, but then re-auditing the adherence until you start seeing the point where you get 100% compliance with the pathway. And it's just that constant, that kind of drive for excellence, really. And I think it's a healthy governance process in that regard.
Absolutely. And if we don't add to the literature base in a pragmatic way through audit data and case studies and examples that are then used in various different ways of utilising the scientific method to inform the literature, then some of the myths around just how rare these things are will only continue to be perpetuated, and people then perceive that these are things that they cross their fingers on that they might not encounter in their entire careers. We sometimes get new clinicians that perceive that, oh, I hope I never get someone that might have a cancer presentation in my career. It's sort of like, well, you'd be lucky to not see one this month or this year. And one of the reasons why those things get perpetuated is because of sometimes old data, a little complacency, and the difficulty that happens when we're trying to make something numeric when it is rare in a general sense. Because it makes it look small, but even 1% is only 1 in 100. We see plenty of patients, don't we? So I think that's a great point to finish on as well, with regards to making sure that we add to the numbers by making sure we're auditing and keeping an eye on those practices, because the consequences, as you said at the start, the consequences are so grave in this particular area. So thank you so much. It's been an incredible chat. We best wrap up. Can you please direct the listeners, anything else you want to add first, but then also direct the listeners to your work and where they might find you?
Absolutely. I'm just going to probably say that my first paper I published was a case study, so I totally agree. Case studies are of great value. So where people can find me, well, from a clinical perspective, my private practice is sheffieldshouldderphysio.co.uk. You'll find me on Twitter. My handle is @AndrewVCuff. In relation
V for what? Victor?
I'm not telling you what the V stands for.
Vanessa.
We'll go with Victor if you like. So in terms of my teaching, I teach on the upper limb. So I teach with my good colleague Thomas Mitchell, who's the UK's most recent Mulligan concept teacher. And we teach a course called the Complete Upper Limb course, which takes people through the spinal spine down to the hand, and it's accredited by the Mulligan concept. But also through my role with USA, there's a 10% discount for all USA members. This year, I'm teaming up with a venture with Jack March. So obviously, it's kind of a good part of the Physio Matters podcast. We're doing a 2-day course on red flags, serious spinal pathology, systems thinking, but also identifying rheumatology within MSK.
Thank you so much for coming on the show. It's been a brilliant chat, and I'm sure the listeners have got an awful lot from it, and they know where to find you now. Hope they visit you on some of your courses, and also you'll be speaking at the Big R's in April, which we're excited to hear your thoughts on. So one of the people that, since I've been in the social media space since we launched Physio Matters, always been someone that's been supportive of what we've done. Also someone that's willing to scale his thinking through the clinical, through the operational, to the organisational, and someone that's always a font of knowledge on various things and willing to share his thoughts, whether they're embryonic or well developed. It's always great to hear from you. So thank you so much for coming on today. Really do appreciate it.
Pleasure, Jack. Thank you very much for inviting me.
No bother. There you have it. Absolutely mega chat with Andrew. Really enjoyed it. Learned a lot. Do check him out at Andrew V Cuff on Twitter. I'm Jack A. Chew on there, and then at TPM Podcast is where you'll find all the information regarding up and coming episodes. As I said at the start of the show, check out the events that we're going to be doing, and we'll live stream as much of that as we can. But certainly, people getting a lot from the events that we're doing, and the conversations that we're having in person means you can wade in, and we're always massive question and answer sessions at these sorts of things. So people are certainly getting a lot from that. So I hope you do too, and check out social on Facebook, particularly where we do a lot of the live streams. So that's where you can get extra material from us. But that's pretty much all from me this time. iTunes often tweak their algorithms and stuff, and more recently, apparently, like the ratings and reviews and stuff matters to reach and things. So if you don't mind, if you enjoy what we're doing, then please do give us a review on iTunes and give it a rating, just to help us to tap into more of the health market, because it does wax and wane, and we find out after the fact that sometimes the ratings and reviews do matter for periods of time. So we've got great loyal listenership, lots of feedback, but we don't necessarily plug for that review. So please, especially if you found us on iTunes, then please do give us a review or rating on there. It'd be much appreciated. And for a change, I actually remembered to get our guest to say the famous cheesy sign out. So I hand you back over to Andrew to see us out.
You've been listening to the Physio Matters podcast, discussing physio matters because physio matters.